Corey's right. There is nothing in the literature on this. I want somebody to tell me where the article is, because I use PubMed about every 3 hours. There's nothing on this. Everybody talks about it, but there's one series of studies that I think you need to be familiar with. And I also think you need to be familiar with the magnitude of this problem, which is bigger than you think. And then you need to think about whether you're going to take this back to where you work and do some changes about it. Forward. Here. So, what actually are the standards in the literature with regard to getting lymph nodes out for thoracic surgeons? And for patients with resectable lung cancer, how actually good do we do in getting the mediastinal lymph nodes? And does the approach have anything to do with how many lymph nodes you get? And does that make a difference? And is this a problem only with mediastinal lymph nodes? And if you recognize that there's a problem, and believe me, there is, what can be done about this? So, and then the minimal part of this lecture is, what are we going to do about this now when confronted with this situation in the clinic, when there are no recommendations with regard to what to do about this? So everybody knows this. This is the new staging map. But not everybody knows what the standards are that are written in the literature for what surgeons have to do for you. And you need to look at the pathology report and see whether that surgeon has met those standards. So a systematic nodal dissection is really not even a complete mediastinal lymph node dissection. It's a great sampling in which you sample certain areas consistently and regularly, and you end up with a number of lymph nodes. So when you're doing the right upper lobes, you've got to get the high, middle, and low paratracheals as well as the anterior pretracheals. You've got to get the level 7 lymph nodes. When you're doing the lower lobes, you've got to get the level 7s, you've got to get the paratracheals, lower paratracheals, and you've got to get the paraesophageals and the ones in the ligament. On the left side, I can't show it to you very well, but you got to get those level 5s and level 6s, plus all the rest of them on that side. And then on the left lower lobe, you got to go back and do the same thing that you're doing on the right, which is subcarinal and then down. And you have to get out a minimum of 6 nodes. I'm not making that up. It's written in the literature. It's 6 nodes. And 3 of them should be from intrapulmonary, the quote, N1, and 3 of them should be from mediastinal stations, and they should be from different mediastinal stations. So, anybody know how many nodes you really can get if you get all the lymph nodes out? You'd be surprised the number of lymph nodes. It's a number to remember, so you go back and look at your pathology reports and see how many lymph nodes your surgeons are getting you. Here's an old study. And in fact, it addresses the issue of VATS versus open thoracotomy. The number of lymph nodes that you can get approaches 30 lymph nodes, okay? These are not fragments. This is 30 lymph nodes. And that can be from both, that's N1 and N2, and what you should also see is that you really don't have much of a difference between VATS for people who know how to do VATS and know how to do the maneuvers to get those lymph nodes, as well as open thoracotomy. But remember also that this number is not just the surgeon's responsibility. Whose responsibility is it also? It's the pathologist's responsibility. We'll get to that. So we do horribly. There are 2 big studies. This is an older one from the American College of Surgeons, in which, looking at 11,000 patients, 42% had no mediastinal staging. I'm talking about the N2 lymph nodes now. And then in the highly used STS database, if you looked at patients operated on here and then the analysis done, 35% in the STS database, thoracic surgeons support that database, send in their data, 35% did not have a mediastinal evaluation. Not the greatest for surgeons in the United States, and that is a mixture, by the way, the STS database, of both academic and community hospitals. Well, the first and the biggest SEER study that really looked at this, and SEER has a lot of problems, but SEER is big, and SEER represents a mishmash of community and academic. If you look at this was done by Malcolm DeCamp in 2009, in which he looked at 24,000 patients from the SEER database who had complete resections. And what he found was that lymph node examination impacted survival, in that if you did a lymph node examination, there seemed to be an increased survival from 42% to 58%, as well as a change in the disease-free survival. And he showed very nicely that there seemed to be this pattern that as you have more lymph nodes removed, you seem to do better. You also had patients who didn't have very good nodal dissections. Less than a lobectomy in these 24,000, 70% did not have a nodal dissection. But the SEER database is used by multiple people and has been updated. And there's a group in Memphis that really has looked at this problem very carefully. And their data really is important that you understand, that because they've recognized it, they've published it, they've done something about it, and they in fact have a grant from the NCI to be able to take this national. And this is where this has to go. This is their first publication in which they looked at mediastinal lymph nodes, looked at neglected lymph nodes after the DeCamp study, and did a very stringent how they were going to put these patients in, complete resection, some with lymph nodes and some without lymph nodes. And they could define who's going to get a good lymph node examination. Okay, women seem to get better, whites seem to get better, upper lobe tumors, a little bit easier, stage 1 disease, poorly differentiated tumors, big tumors, and pneumonectomies, because it's going to take everything out, so you'll have a lot of lymph nodes. Those are the people that get a good lymph node examination. And when you do a good examination, you get more lymph nodes out. And they also validated, at least what was found in the first SEER study, that if you do a lymph node examination, you do better than if you don't do a mediastinal lymph node evaluation. Now, this is the leader of the pack in Memphis, Raymond Osara Gyangban. And he's had a real interest in this, starting with that paper. And what he actually did was sort of treated surgeons as children, which they actually are, and made a kit so that in the operating room, you would have every station sort of put with formalin so that you were obligated that if you went on this trial, you had to do this and you were known whether you did a good lymph node dissection. So we adopted that not only from Memphis, but from the Southeastern Consortium of Surgeons, thoracic surgeons. And this is what he presented at World Lung from his group, which is the compilation of using this kit at least. The early adapters, you can see that it increased as time went on as to how many of those surgeons actually used it. But the results of using the kit are actually pretty interesting. You had more patients that actually had a lymph node looked at. And this is from the surgery. So you went from a 9% NX to less than 1%. The number of no mediastinal examinations went to 0. The rate of resection of the hilar lymph node, level 10, which is actually an important one because that's easy to get for us as opposed to the intralobar or intralobular ones, went to 4%. So more of them were being taken. And then the rate of resection with no levels, so no subcarinal lymph nodes, which is the one that we all scream at sometimes, went to 3%. So using the kit actually did make a difference for these people in how many lymph nodes they got, what stations they got, and the data's not in yet on whether it's going to make them live longer, but that will come with time. But here's the other part of this. Corey asked me to talk about mediastinal lymph nodes. This is not an issue of mediastinal lymph nodes. And when you hear Gerard talk about the new staging system with N1A and N1B, do you really think the pathologists are aware of how to look at those lymph nodes when they get a piece of meat from us? They're not going to know how to do that. And we're not going to be doing that in the operating room, unless we have a kit like this, or unless we learn this type of Japanese way of doing the lymph nodes, which we have to do now because it's going to be mandated by the World Lung. But it's not just a matter of N2, and let me show you, because the Memphis group has also looked back at SEER, and not just concentrated on the N2 lymph nodes, but concentrated on what the impact of NX is when it's an NX-N1 lymph node dissection. And this was a later publication, so they had more patients to look at, but they had 15% who had no N1 disease looked at. These were older patients, and they had, surprisingly and not surprisingly, lesser resections. So it's almost like we sort of say, well, it's an older patient, we don't need to get more lymph nodes out, we don't need to look at the lymph nodes that extensively. 54% of the patients had a sublobar resection in the NX group, but also in the greater resection group, 35% had no information on N1. I mean, that's pretty phenomenal. And N1, partially surgeons, but also partially pathologists. If you looked T-stage for T-stage as to what the effect of not having information on the N1 nodes, and you compared that to how N1 patients who are involved actually do, the NX group looks just like the N1 involved groups. Are we missing patients that way, that have lymph nodes? That's an obvious answer. The number of lymph nodes is about 6 that they got out. And again, NX and N1 versus complete dissections. So it may have prognostic import. And what we've learned so far from this is that uncertainty regarding lymph node status can have prognostic implications. As high as 33% of the patients presently with lung cancer have this uncertainty, and there may be a relationship between the number of lymph nodes removed and prognosis, including N1. Now, surgeons can be buffoons too, in that surgeons dictate operative reports. Well, the Memphis group went back and looked at their operative reports to see whether their operative reports talking about lymph node dissections actually was concordant with what the pathologists got. So they had 748 resections. They actually relaxed the criteria as to what a real lymph node dissection was. The bottom line is that there was only concordance between the operative note and the pathology report in 39% of the cases. That's astounding, because we have our residents actually write a little brief op note that tells exactly what we took out and all that sort of stuff. 39%. And then they had an independent surgeon come in and look at this so that it doesn't seem like they're biased, and they found it was a little bit better, 49%, but still half and half with regard to whether the operative note, which is going to go to somebody to look at to try and figure out what's going on, is not going along with the pathology. And none of the mediastinal lymph node dissections were actually a dissection. Now, the surgeons are not the only criminals. You have to look at the pathology also. So that's what they did. They took 73 consecutive lobectomies, and did pathology examination at 2 stages. They did it immediately for the report, but also they went back after his formalin and did thin cuts and looked to see how many lymph nodes actually weren't looked at in the specimen, the N1 lymph nodes. And they called that special pathology examination SPE and the routine RPE, and here's what you find. Here's the RPE, and here are the additional SPEs as far as number of lymph nodes. So the number of lymph nodes found on the routine was about 4, but you get an additional 6 when you did the other examination, the more controlled examination. And then if you look at how many were positive, the total number of lymph nodes that are positive in these 73 patients, 34 had N1 metastases on the routine, 90. Now, it's the same patient, but when you're talking about gross disease and whether it matters a number of lymph nodes positive, this may be important information with regard to how we're going to change the management in the future. And in fact, you changed the stage of these patients in that you found that there were more patients with N1 disease going to stage 2 and more patients with positive lymph nodes. So how do you put this all together? Obviously, it'd be great to have a paper where you had the kit and you had the pathology examination and you could see what actually happened. They did that. So they had 100 patients that had been operated on a previous time that didn't conform to these new things, the kit in the operating room and the pathology examination that was a 2-step, a real precise examination. And what they found was that compared to controls, the number of N1 lymph nodes was increased. The number of positive N1 lymph nodes was increased remarkably from 1% to 3%. And then any positive lymph node present almost doubled. And obviously, that had impact for whether patients were going to get treated or not. So I look at this problem like this. What's in your hospital? And are you having the same situation that the Memphis people have concentrated work on and pointed out to us that we were all sort of just having as the elephant in the room? So, what are you going to do about this now? Well, I thought about this and I asked my MDL and they looked at me like I was nuts. But here is what I think, at least. You got a situation where you have no mediastinal lymph nodes, and you had lobar or segmental resection and revealed, and it was pretty good, and you have no positive lymph nodes in the specimen. So you don't know what the mediastinal nodes are, but you know that the intrapulmonary lymph nodes are negative. Some of the things that I take into account are how old is the patient and what is their functional status. When was the resection? Because there is this wives' tale about you should treat earlier than later to have this be effective as far as adjuvant therapy. Did the patient have a PET CT? Can you go back to that PET CT and look at it and see what the deal is? And can you also look at the diagnostic CT? How hot was the lesion, the primary lesion? Was there any lymph node in your view of that PET CT, and I'm not talking about the report, I'm talking about you looking at the PET CT that you think is above background. How big was the lesion? If it's less than 2 centimeters, then the chance of an N2 positivity is low, but still there. And then what's the pathology of the lesion? And I think this is a very important situation. So if I have a patient that had no lymph nodes taken, had lymphovascular invasion, but no N1 disease, and had a hot PET, I'm thinking about presenting that case in the MDL. Should we look at those lymph nodes now? Okay, the other situation is just a complete disaster in which you have no N2 lymph nodes and the lobar segmental resection reveals N1 lymph nodes. Now, maybe it's a little bit easier because those patients are going to get chemotherapy anyway, okay? But is the idea that they're going to get chemotherapy anyway sufficient to excuse the fact that they weren't adequately staged? And, we don't know the results of the lung art. We don't know whether we're going to add in young patients radiation to the potential patient who has mediastinal lymph nodes that are found postoperatively, adjuvantly. Is there a consideration that you're going to add radiation to these patients? And then if the patient had a large tumor and positive lymph nodes, maybe you ought to go back and see, because you may add radiation therapy. So what are the options? Do nothing and follow with PET-CT or CT, and if the nodes change, then restage. I already showed you a couple of instances that I look at that makes me a little bit more concerned about that. And if you restage immediately, then I'm all for what Gerard says. I think they ought to start with an EBUS. But that may depend upon what side the patient had the lymph nodes on, and probably only for high-risk patients for nodal disease, meaning high SUV, large tumors, positive margins, or lymphovascular invasion, at least for me. But as the final statement, the bigger question about this lecture is whether nodal station now needs to be a national quality initiative that's going to hold surgeons to the standard that we've been talking about for such a long time, that now with the implications for prognosis as well as therapy, it needs to be on the docket, that there has to be some mandates. So for this lecture that I could not prepare, I thank you.